Hi, all, and welcome back to Professor Truelove's Concepts for Nurses series. And in this episode, we are going to cover one of the many ways on interpreting an EKG. And I'm going to use a specific type of algorithm to help you quickly learn how to read these up and down patterns called the EKG. As I said, there are many ways to interpret this ECG. This is one that I think will really help you at the beginning. No matter which algorithm you decide to use, always use that algorithm. In other words, don't cut steps out. It's when you try to take shortcuts that you will end up making a mistake. So in this case, ask yourself, is this rhythm regular or irregular? You should then ask, what is the rate? Are there P waves present? Fourth, is there a P wave for every QRS? Or think about it conversely, is there a QRS for every P wave? What are the intervals? You should evaluate the T wave, and then the ST segment, and then evaluate for any other component. Once and only after you complete steps 1 through 7 should you attempt to give that pattern a name. In other words, interpret that EKG. Step 1. Is it regular or irregular? In a regular rhythm, the intervals are constant. And when I speak of intervals, I mean the P wave to the P wave, or the P to P, and the R wave to the R wave, or the R to R. If it's regular, those intervals are always constant. Now, another way to think about it is that it's irregular overall, but you can see patterns within that irregularity. In other words, you might have 3 that look like they're in a pattern, 4 others that look like they're in a pattern, then back to the 3 that have a pattern, etc. You can't say that it's regular, but you see patterns within that irregularity. Lastly, is irregular. In an irregular rhythm, you see no pattern at all. Here is one way to measure for regularity. In this case, we're looking at the atria and the ventricle and when they fire. And remember, that's represented by the P waves and the R deflection of the QRS. So the atrias are the P waves and the ventricles are the R waves. And if we are to march these out, we will see that the interval between the P waves or the R waves is constant. On this specific waveform, we would be looking at a regular pattern. However, if there are some irregularities, see if there's overall regularness. In other words, look at the overall picture. Is, for the most part, the rhythm regular, and you just have 1 or 2 extra beats that are happening either a little early or a little late? Well, if it's early, that is before the next anticipated QRS complex, we call that a premature complex. And it depends on where it's coming from, on what label we give it. So there are premature atrial complexes, premature ventricular complexes, and premature junctional complexes. With a PAC, it's an early normal PQRST complex. With a PJC, you have an early beat with a narrow QRS complex in T waves normal with absolutely no or an abnormal P wave. And a PVC is an early, wide and bizarre looking QRS with no P wave. If the next impulse, that is the next complex, is late, that is after you would expect the next regularly conducted beat, we would call that a late or an escape beat. And in this case, you will have a junctional escape beat and a ventricular escape beat. In a JEB, this is a late normal looking QRST, but with no or an abnormal looking P wave. And a ventricular escape beat is a late in an abnormally wide or bizarre looking QRS complex. Besides determining if you have early or late beats that are isolated, it's important that you determine again if there's patterns, because determining the patterns will help you to interpret the ECG a little later on. there are certain rules or facts about specific rhythms that can be determined by the pattern, that is, by the regularity of the ECG rhythm. Once you have determined whether the pattern is regular or irregular, try to determine the rate. Do this by counting either ventricular, that is QRS complexes, R waves, or the P waves. If there is a difference between the atrial rate and the ventricular rate, such as in a block, count both and list both separately. In addition, for certain type of patterns, for instance, in different types of AV blocks or atrial flutter, you should also identify how many of the different types of waves are occurring. If you're counting atrial flutter, you'll count flutter waves, and you'll compare them with the number of QRS complexes, and you will give that a ratio. But first, you have to determine how fast the heart is beating. There's a number of ways to do this. One way is the 6-second method. In the 6-second method, you simply count out the number of R wave deflections in a 6-second strip, multiply that number by 10, and get a rough estimate on what the rate is. With the 300, 150, 100 method, what you do is you find an R wave that is very close to one of the large boxes. You use that as your starting point. Then, for each large box over, you label it with one of the following rates, in going from left to right: 300, 150, 100, 75, 60, and 50. And the next thing you do is you look for where the very next R wave occurs. You use that R wave, you go up and you determine what number is given for the rate. In this example, you will see that from the start here R wave, the next R wave occurs just to the left of the 60. So it would be safe for the nurse to say that this rate is approximately 70 beats per minute. Those two methods are fine to use in a hurry, when you just have to get an overall view, a glance at what the heart rate is. But if you're trying to interpret an ECG, it is important that you are as accurate as possible. And the most accurate way to determine the rate is called the 1500 method. So you should always use the 1500 method. This method uses the small boxes. What you do is you count the number of small boxes for a typical R to R interval. You divide that number into 1500 to determine the heart rate. Now, what you want to do here is you notice that the interval between 1 R and 2 Rs is about 22.5. That means you take 1500 divided by 21.5 and come up with a rate of 69.8. If your heart rate is irregular, you should always use the 1500 method. Measure the longest possible distance between R to R and the shortest possible distance between R to R. Determine the rate of the longest possible distance and add that to the rate of the shortest possible distance and divide that number by 2 to determine your average heart rate. The next question you should ask yourself is, are there P waves present? And not only are there just P waves present that you can see them, are they the same size, are they the same shape, and are they in the same position? If they are, that indicates that there's some regularity going on. Is there a P wave for every QRS? Remember, in a positive lead that normally the P wave faces upright and is uniform. As we are looking at our P waves, we need to know that they are representing atrial activity and even sinus activity. Because the presence of regular P waves or the absence of P waves or abnormal P waves tells us which area of the heart is acting as a pacemaker. That is, where is this energy coming from? If the P waves are not uniform, that is, look exactly the same, then the impulse may not be coming from the sinus. It may be coming from the atria, the junction, or the ventricles. So rhythms that have a normal QRS complex And a regular rhythm include atrial tachycardia, paroxysmal atrial tachycardia, atrial flutter, junctional rhythms, and supraventricular rhythms. Rhythms that have a normal looking QRS but are always irregular include atrial fibrillation. Rhythms that have an abnormal QRS complex and whose rhythm is regular include idioventricular rhythms, accelerated idioventricular rhythms, ventricular tachycardia, and heart blocks. If the rhythm has an abnormal QRS complex and is also irregular, you may be looking at escape beats, premature beats, or even polymorphic ventricular tachycardia. Once we've established about the P waves, the next thing we ask ourselves is there a QRS for every one of those P waves? If there is not a QRS that follows every single P wave, consider a second or even a third degree block. You should also ask yourself at this time, do these P waves look the same? Because if not, you should ask yourself, are those actually fibrillation waves? Or are those something like flutter waves? Is it artifact? Could this be a wandering atrial pacemaker? In step 5, we start to look at intervals. What are those intervals? Well, we need to know about the PR interval, the QRS complex, the QT interval, and even some things about some of the other segments. Take a good look at the diagram and try to remember where the PR interval begins and ends, where the QRS complex begins and ends, and what it is to be a QT interval, and where a QT interval starts and where a QT interval would end. The PR interval, or PRI, is normally between 0.12 and 0.20 seconds and is always constant. That means the intervals are always the same. If the intervals are not the same, we call that a variable PR interval. That happens in certain types of AV blocks. Next, measure the width of the QRS complex. Normally, the QRS complex should be between 0.04 and 0.12 of 1 second. That is, between 0.04 and 0.12 seconds. If the QRS complex is greater than 0.12 seconds, then consider that the impulse is ventricular in origin, such as a premature ventricular complex or a ventricular escape beat. Or it is because the impulse is going down an aberrant pathway, as in a bundle branch block. If there is no QRS, there is no ventricular activity. You should also be looking at the shape of the QRS. If they are normal, they are all the same shape, and that means you'll have a single deflection for the Q wave, for the R wave, and for the S wave. But sometimes, as in a bundle branch block, you will have double R waves, which are sometimes referred to as rabbit ears. Also, the shape of the QRS should be relatively narrow, that is 0.04 to 0.12, and should also always be in one direction. If they are wider than that and they look very bizarre, then the impulse is ventricular in origin, such as in a premature ventricular contraction or ventricular tachycardia. And this is because the shape of the QRS is determined by where the impulse came from, that is, its origin. If it's normal and you have one type of abnormal QRS, that is, the PVC or the PVCs all look the same, those PVCs, those early beats coming from the ventricle, are coming from one area or one foci. And these are examples like unifocal premature ventricular complexes. Now, if there's two or more different shapes from these wide, bizarre QRS complexes, then we know that these extra, either early or late beats are originating from different parts of the ventricles. We call that multifocal, as in the case of a multifocal premature ventricular complex. Again, this means that these impulses are coming from different areas within the ventricle. Sometimes these PVCs may occur in patterns, and if they do, There are names for these types of complex groups. When in bigeminy, it is a repeating pattern of a normal and then a premature beat, and then another normal and a premature beat. In trigeminy, it is also a repeating pattern, but in this case, there's two normal beats and then one premature, and then two normal beats and then one premature that repeats over and over. In quadrigeminy, it's a repeating pattern of three normal beats and then a premature. With something called a couplet, there are two consecutive premature complexes. And in a triplet, there are three consecutive premature complexes. If four or more premature complexes occur in a row, that's called a salvo or a run. You should know that runs are longer than salvos. There is no hard number that determines the difference of a run and a salvo. Also, you should look at your QT interval. Here we have a very nice picture of normal and prolonged QT intervals. Normally, the QT interval is between 0.36 and 0.44 seconds. A prolonged QT can be caused by various factors, and it can also cause lethal arrhythmias. Now, that being said, you should know that in a faster rate, as in a tachyarrhythmia, the QT intervals, even in a sinus rhythm, will be shorter. And in a slower rhythm, even if it's sinus, the QT interval will tend to be longer. Step 6 is to evaluate the T wave and the ST segment. Now, a normal T wave should be about half the size of the upward deflection of your QRS complex if you're looking at your EKG from a positive lead. Now, this T wave and the ST segment may change because of electrolyte imbalances, because of oxygen levels, temperature changes, and for various pathologic reasons. It is important that you clearly delineate where the ST segment is and not start counting the ST segment from the S wave. Not using care can result in the nurse interpreting an otherwise normal ST segment as something abnormal or even pathological. Because the ST segment should return to the neutral midline level, that is the isoelectric line. Changes may indicate the patient has problems or their equipment problems. And these changes may be benign or they may be very harmful. So care should be taken when evaluating the ST segment. At this point, you're nearly done with your interpretation of the ECG waveform, and you're about ready to give it a name. You're about ready to diagnose. But before you do that, you should evaluate other components. Determine which lead you're actually looking at. You may be looking at a negative lead thinking that, oh no, the QRS is deflecting the wrong way. Summarize your findings, and also, especially if you're new, utilize resources. If you're a nursing student, find your instructor, find the RN, and bounce it off them. What do you think this is? Have them verify that interpretation. And also, if you're looking at something strange, especially if you're looking at artifact, and you're not quite sure what it is, consider that there might be some non-patient related causes. In other words, equipment problems. These steps then are designed to help keep you organized as you attempt to interpret the EKG. That is the end of this episode. However, in upcoming episodes, we will start to look at sinus, junctional, and ventricular rhythms. That is, rhythms that originate from the AV node, the SA node, and the ventricles. I am Professor Truelove. I hope you learned a little bit, and I hope you come back soon. If you do, we'll see you then.